All right, let's start the meeting first. Members, we've already got 5 members, so we have a quorum. Let's start. Please invite the government representatives to come in first. You have noted that we still have a number of outstanding papers because after every meeting, the administration had to submit replies to us, and we had to discuss the replies here. Sometimes we had to repeat our questions. Well, this Bills Committee has been in existence for quite some time already. This is already our 10th meeting. Time flies. So we really have to proceed as expeditiously as possible. We have 3 outstanding responding papers submitted by the administration in July, October, and November last year. The contents of the paper are repetitive in certain areas. So I'd like to ask the administration to introduce the 3 papers to us in one go, such that members can ask questions about all the 3 papers. After the discussion, we'll see whether there are any follow-up questions. We've got 10 meetings already. I think it's time for us to proceed to clause-by-clause scrutiny. The Privacy Commissioner had made some suggestions, and the administration had responded. In recent times, organizations and individuals have sent in their submissions as well. I'd like to proceed to clause-by-clause scrutiny as soon as possible. So later we'll look at our meeting schedule and so forth. So let's proceed. As I mentioned, we would invite the administration to go through all the 3 outstanding papers to us in one go. Dr. Leung Ka-Lau, thank you, Chairman. Chairman, just now you mentioned that in recent times we received organizations and individual submissions. Do we have to discuss them as well? If any member has any comment on any of the submissions, he is, of course, free to raise the comment. Otherwise, we don't need to discuss them one by one. The content of those submissions might have already been mentioned in public hearings. So, Dr. Leung, any special comments on the content of those submissions? As so many people have submitted submissions to us, we have to clarify whether or not there are special comments in those submissions. First of all, I have to say that I have to apologize for the fact that I might not be able to attend each and every meeting. In recent times, have we received or have we requested any organization or individual to send in submissions? No, we never put up such requests. So why is it that in recent times these submissions emerged? I mean, suddenly. I won't like to speculate on the reasons. We received a few submissions recently. I think about 6 to 7 of them. After receiving the submissions, I read them, and the Secretariat would ask me whether or not I would like to circulate those submissions to members. Basically, I circulated all of them to you. In simple terms, those submissions would like us to scrutinize the bill as early as possible. Apparently, there are no new points. I do not like to speculate on the reason for these 6 to 7 submissions coming in recently. At the meetings of the Bills Committee, when we discussed the details, the administration said that at the beginning of the consultation exercise, it received comments and views from the professions as well as individuals. Maybe you should look at the submission from the Hong Kong Medical Association, which was addressed to the administration. The reason is that the administration requested the profession to submit views to the Bills Committee. The administration, for example, the administration sent a letter to the Medical Association asking the association to submit views to the Bills Committee. Is this in order? Chairman, in simple terms, all these submissions, though addressed to the Bills Committee, were actually requested by the administration. The only one that I'd like to mention is the one from the Medical Association, of which I'm a member. I explained to them the details of the bill, why we need to have so many meetings for discussion. The Privacy Commissioner also has comments and so forth. After listening to me, the Medical Association agreed with me, so they wrote in. Rather, they wrote to the administration, copying the letter to us. I don't think this is really in order. I don't know the past practice. In the course of scrutinizing a bill, the administration did something at the back. The Bills Committee did not request for these submissions. As you mentioned, we had already had public hearings, and as you said, there are no new views in these recent submissions. So, is this in order? In my opinion, our rules of procedure and other rules and regulations do not specify that any associations or individuals should exert pressure on us. Of course, nobody can stop them from doing so. You ask whether this is in order. Dr. Leung, you know, this is a political judgment. Well, members can judge whether or not the administration was correct in doing so. I won't be the referee. My duty here is to follow the procedures and scrutinize the bill as soon as possible. Of course, I won't refrain from saying what I should say. I will not deliberately delay the scrutiny exercise, and all along this has been the practice of Bills Committees. Well, Mr. Chairman, I did not observe that the Bills Committee was deliberately dragging this on. Perhaps we should look at the reply the Medical Association sent to the government. The association is very concerned about public privacy. It considered the worry of the Privacy Commissioner. The arrangement proposed is that the medical service provider is the institution, the medical institution, rather than an individual. So the whole personnel of the institutions, whether or not they can scrutinize the patient's records, really depend on the monitoring measures adopted by the institution concerned. Such conditions are not set out in our laws. So the view of the Medical Association is that the major purpose of this bill is to protect the privacy and rights of patients. If these issues are not clarified, it is not necessary to hastily pass the bill, because we all support electronic medical records or health records. But even without this bill, electronic health records have been in place for quite some years for exchanges in mutual directions. Whether or not we have this bill, that will be in existence already. So to protect the privacy and interest of patients, we should not hastily pass the bill. Rather, we should listen to the views of the Privacy Commissioner. Then we should engage ourselves in detailed deliberation. Have you finished with your comments? I have a second point. I think the other members need to know that insofar as this bill is concerned, apparently patients can participate voluntarily. But in future, the government will introduce another piece of legislation to regulate private medical institutions.
Which means that the government will make it mandatory for these hospitals to participate in this EHRC system. And the sum total of the effects would be the following. If there are patients who do not want to make his records known to the government, then he would go to the private hospitals. And given the two laws, then the records of the patients will actually go into the electronic health records. And the government, that is to say, even if the patient wants to withhold certain information from the government, but the government will finally know anyway, because this particular bill, together with the private hospital bill, together the sum total effect is that the government will have all information. Well, the Medical Association is in the know about these details, and they have therefore raised this, but not some of the other bodies. Now, Dr. Leung's point had actually been raised before. The government had also heard the views as raised by the members and their concern, and we need to clarify. Well, Dr. Leung, thank you very much for the clarification concerning the Medical Association's view. That is, it is not just about the individual, but organizations getting their hands on the information or records. We would like to thank Dr. Leung for the view, and members would also take note. And a second point which you have raised, which have not been covered by the previous meetings, and that is for private hospital bill. I think at the right time, later on, perhaps the government can respond to that as well. I think that would be, in a way, a response to the Medical Association as well as to Dr. Leung. And the other letters, it seems, as far as I can see here, do not raise any new points. Perhaps we go back to perhaps Lee Kwok Lun. Mr. Chair, concerning Dr. Leung's second point, the government should respond to his point at this point. Now, if the Medical Association's concern is something that we should discuss, and that is the private hospital bill, well, it is not law yet. It is in the bill form. I do not know the timing for that bill, but if in the legislative process of that particular bill, if it impacts this particular one, that is on electronic health record sharing system, then I think we should take that into consideration in tandem. A second point I would like to make is that we're still talking about the safe deposit box, and we're still talking about confidentiality of patients' records. We're still talking about the same old points. I mean, the government would have responded to those as well. I mean, at this point, should we not go clause by clause already, having covered all these points already time and again? I mean, if the government is still, unhappy and would not respond, then we should do a CSA. Otherwise, this will drag on forever till the next year. I mean, it would be quite meaningless, and perhaps we won't even have a quorum for the meeting. I'm not saying that somebody is dragging their feet or anything, but on the other hand, perhaps some people are counting the votes. I do not know, really. But if there are still points where both sides cannot agree on, well, go to CSA. I mean, the Privacy Commission had raised certain points, and the government had made certain responses concerning the confidentiality and the protection of the rights of the patients. I mean, there's been a lot of toing and froing, but basically it's been the same. I mean, if that is a situation, let's not drag it on any further. I mean, every time we raise the same views, we hold the same views, they hold the same responses. I mean, I think the chair should be decisive. I mean, let's go clause by clause. When we get to the points, then let us discuss those points there and then. Yes, that's exactly my point as well. I do not want to go through these issues again and the government come back with written responses again and go back to the responses and the previous meetings, discussions. Well, that would drag on forever. Yes, indeed, members have had the chance to raise their concerns, and there have been written submissions as well. And, of course, when we come to clause by clause, if members are still dissatisfied, then we can go for CSA. Now, Ms. Fan. Mr. Chair, I am concerned about the number of submissions we have received. And the industry had come to me asking whether this panel is dragging their feet, or which panels or bill committees are filibustering or dragging their feet. Well, I have to say that we have not been filibustering, but I just want to say that we have received, or I have received, views from the industry and from the citizens at large, and I would want to reflect that here. I mean, we have asked a number of questions, and the government had made responses, drips and drabs, and we have discussed those. I do not know how we can speed it up. I mean, we have been serious in our discussions. It's just that, Mr. Chair, we have discussed some of the points various times. Doesn't mean that we can skip the discussions and just pass this. I am not in favor of that. I agree that we should seriously discuss all the points. But on the other hand, it is also true that there are certain members who were not at certain meetings, and they come into into subsequent meetings and ask the same questions that we have covered in previous meetings. That is true. And a further point, I do not understand why it's been alleged that the government is asking different bodies to write in. As a result of that, we have spent a lot more time just on the basis of this. I mean, if the government can face our concerns and address them, that will be simple and straightforward enough. I also not believe that we are dragging the process. We're not dragging out the process. Now, Mr. Lee and also Dr. Leung have both raised a point, and that is the Medical Association had raised a possible a bill that may possibly come into law at some point in the future. Perhaps at this point we should respond briefly on this point. Perhaps you are able to do so, the administration. It is related to this bill. But on the other hand, I'm also concerned that it is in the future we may not have all the information. But on the other hand, throwing light on the relevant bill would perhaps be useful. Yes, Mr. Chan, please. Thank you, Mr. Chair. The administration would like to say that from the government side, we certainly do not believe that there is any filibustering in this bill, or the Bills Committee, and we are not dragging our feet. And it is exactly because we want to do a good job, therefore we have discussed some of the points time and again, and we are discussing those seriously. I mean, I want to clarify that point. A second thing is that 5 years ago, when we first started the electronic health record sharing system and its design, we have for the IT patients and also medical groups, we have approached them. Well, of course, if they are members of our working group, they have already had their views reflected. If they're not members, then they would make submissions to us. In fact, our office would receive such submissions regularly. And also, in certain meetings, when we talk to them, we also emphasize that if they have any new points, they can always write to us or go to their delegates in the working committee and reflect those to us, or come directly to us. And in that midst, we have received a number of submissions and views, and we're not surprised by that. Now, the Medical Association had written to the administration, and they mentioned 2 points that they have observed. Since 5 years ago, so when we first kicked off this system, they have been very supportive, and they've been on the supervisory committee. Now, in the May public hearing, they have also said that they support this particular bill and also the procedures for the examination of the bill. Of course, they have their certain points of concern as well. Now, on the 8th of January letter, there are a couple of concerns. The first issue is that they know that lately we have been in contact with the Privacy Commission on the need-to-know principle. And they are of the view that they are concerned and they would like to see a stipulation to address this, the need-to-know principle. And in fact, we have discussed the same point in the past few meetings. And later on, when we look at our written responses, you would know that the government had already added a 35A, a new 35A to reflect this. So we are following up on that. And also we are following the suggestions of the association and also of the Privacy Commission. And another concern is that the present drafting is such that if a person is not using public organization, that is not the HA or the government hospitals, but if the records nevertheless have to be made available to the public hospitals or to the governments, that would be a violation. I mean, that had been raised by Dr. Leung as well. In fact, we have a response on that concerning our views. As for the third point of Dr. Leung, is about a private hospital bill, which is not covered here. That even though I'm not responsible for that particular bill, but it is true that we are in consultation process for governing or regulation of private hospitals. And one of the views therein is that in the future, the private hospitals or institutions should have better facilities and equipment, including electronic health record systems. This is not about sharing or participating in our health record sharing system, but rather for their health record systems to be electronic, to go electronic. So even if we agree to this, the private hospitals and institutions in the future will only have electronic health record systems. It doesn't mean that they have to participate in our health record sharing system. That is to say, certain private hospitals already have that kind of electronic system already, but it doesn't mean that they have to share that with our system. We actually have another team of colleagues who are working on this, and they're working with the health department as well. So that is a brief response to the Medical Association's submission. Dr. Leung, Mr. Chair, I don't want to waste anybody's time. When we come to the point in our clause-to-clause discussions, I would want to go into depth about this issue. All right. If that is the case, would we please go by the agenda, and that is to introduce the papers, the 3 papers, and the responses, and to bring us through the responses, or give us a summary, if you will. And on that summary, let the members ask questions. In fact, we all have the responses already. Yes, there are 3 responses altogether. July, October, and December meetings responses. There are a few issues covered in the July meeting, and that is members have asked the question why in the bill we do not allow written submission or request for health records of patients. Our response was that during the consultation period, certain people were concerned that there are employers or unethical employers who would get the health records, and therefore we disallow this kind of written request and records. Now, this is different from the Privacy Commission's the ordinance. In fact, this is even more stringent than the privacy ordinance. And I do not know whether members are of the view that this should be taken out, but that is the background in any case of why we put that in. And also we have followed up with certain adult mentally handicapped persons and their parents. Perhaps they would have the right to get hold of such health records, and it was suggested perhaps these parents can do so. In the supervisory committee, it was put forward as such. And in our responses, we have made clear that under the mental incapacity ordinance, and also in the it is rather narrow. The supervisory committee and also the guardians, in fact, we have already stated those 6 conditions which would be admissible. But of course, it would not include the requesting for health records under our electronic health record sharing system.
If members don't think this is ideal enough, I think we need to make major amendments to the privacy ordinance, or we should expand the terms of reference of the monitoring authority. Dr. Lau also mentioned another concern of the Medical Association. At that time, we designed, first of all, number one, the patients could participate voluntarily. Why is it that the patient can choose which private hospital or which private clinic to peruse his records, and the Department of Health would definitely be included? Why is it that the patient does not have any choice? Is it unfair to the patient? Technically, can we still modify the system? So there's this doubt. Well, we went back and examined the issue, and of course technically everything is possible. But as for the design flow, we observed the views received during public hearings and in this bills committee. For this EHR sharing concept, we would like to enhance the exchange of records between the public and private sectors. At the moment, the biggest service of provider is the Hospital Authority and the Department of Health. And if a patient wants to participate, we would like to store up his records right from infancy, that is, at his birth. But of course, these records will mainly remain with the Hospital Authority and the Department of Health. So we made it very clear that participation is voluntary. But after participation, records will be inputted into the patient's record with the HA and the DFH. But frontline workers are very busy. If every patient has to be handled separately, and every time explanation is to be offered administratively, the frontliners will have a heavy workload. Technically, we need 1 year for design work. The original intention is to have collaboration between the public and private sectors in sharing the records. So technically, that's against that principle. So we oppose that comment. That's back in July. As for our October reply, the Bills Committee would like to know the participation of experts, professionals, and the medical sector in the whole process. So we studied the membership of the steering committee covering representatives of the medical profession, patient groups, the privacy commissioner, etc. And we mapped out the terms of reference of the steering committee. In the first stage of sharing, what will be the contents of sharing? In the annex to that paper, we set out 9 areas for the common data to be used. Patients' records, adverse responses to drugs, how many appointments with doctors, past medical processes, radiography, records, clinical notes, vaccination at birth, referral records among doctors, and so forth. So that's stage 1. That is the 9 areas of records for sharing. And in the working group, we have a lot of medical experts and professionals. We also made reference to overseas experience and practices for stage 1 sharing. As for stage 2, do we need to wait for the whole 5-year cycle to complete before we add new areas? No. Say by the 7th or 8th years, we had already completed our review on radiography and so forth. We can add new information for sharing in stage 2. And then members would like to clarify, under the bill, the service address will be the only address for obtaining the electronic records. At that time, we're thinking of notebooks to be brought at home. But of course, we would like to have a service address provided, but it doesn't mean that only at the service address can the records be perused. At that time, we discussed a great deal about privacy. Some members would like to clarify the so-called safety boxes. They practice in Australia. And then members asked whether or not there are safety boxes in an emergency. Can the doctor have access to electronic records? In fact, even without this bill, under the existing laws, in an emergency, the medical practitioners can have reference to the patient's medical records. But of course, afterwards he had to offer an explanation. And then members asked us not to have an omission. That is, under what circumstances can safety boxes be decoded and accessed? We'll consider all these comments. That's in the paper of October. And then we submitted another response on the 11th of November. In that response, we explained something. Every time some members asked about the safe deposit boxes, members asked for a study. They're worried that in the end we would do nothing. So in the explanation on the 11th of November, we explained that we would adopt a positive attitude towards the study on safe deposit boxes. That is, we would try to protect the decision-making right of the patient in terms of his records. Why don't we write this into the bill? It's because all along this bill should be technically neutral. It's not a manual. So it will not describe the functions of a system or the architecture of the system. Yet, there's another point. Precisely because we have not conducted the study yet, so we don't know how patients' rights can be enhanced. So we included what's already in place at that time. That's explained in the paper. And then there's this question that with a participating patient, right from the beginning, if he authorizes a private clinic or private hospital to share his records in those 9 areas, if this time he asked whether that particular piece of information not to be shared, would that be possible? In stage 1, there are 5 areas for sharing, but it really depends on whether the private clinic or private medical institution have the ancillary software for sharing. If, say, only software for 6, 7, or 8 areas is installed already, then maybe the 9th area cannot be shared. If on a particular circumstance or occasion the patient doesn't want the information to be shared, the records to be shared, then it is possible for individual private practitioners not to put the records onto the system. But for a doctor in the HA and the Department of Health, he won't be able to do so because all records will be put onto the platform. We explained that to the Bills Committee. And clauses 41 to 46 comprise 6 offences. Members asked for a comparison table for those 6 offences compared with the present situation for those 6 offences. So these are the contents of the 3 responses. I saw a number of hands. First, Dr. Fernando Chang. I'm worried about the mentally incapacitated. Just now the administration said that this bill is something new. Under the present guardianship regime, those 6 powers are not covered. So for a guardian, even if he has taken out guardianship, in law, he may not be able to have the right to participate, withdraw, or obtain records on behalf of the patient. The director said that relevant laws have to be amended, like the privacy ordinance and the guardianship ordinance. But we only have one government. If you introduce something new, a piece of new legislation which is related to other pieces of legislation, then it is necessary for the administration to make consequential amendments to those other laws. You cannot say that, oh, I'm now working on this bill. If other ordinances have to be amended, I'll do that later. Problems may arise in the interim. Last time we discussed with the director and you said that if at present an MIP or mentally handicapped would like to obtain records, then a family member can serve as the patient's representative to make a decision. But there may be many family members, and you adopt the first-come, first-served basis. Now, this arrangement is unsatisfactory. Under the guardianship system, there's monitoring as well as assessment. It's something like an administrative judicial system. There's a third party to pass judgment. The arrangement proposed now is rather wishy-washy. Well, let me cite myself as an example. I am divorced from my wife. If I have a piece of opinion, my wife has another piece of opinion. Should we queue up to ask for guardianship for our daughter? That's confusing. So if you intend to amend other laws, you'd rather do that in one go. This is a concern. If it is not resolved, this bill won't be perfect. I cannot accept the present arrangement as proposed. Can you also comment on other ordinances? Well, Dr. Chung raised two issues. First of all, if the patient joins the scheme, and if a private doctor or a private hospital can access his records, if the patient himself can make a choice, say like a child or a mentally incapacitated, then if a guardian is appointed, the guardian can do that on his behalf. And the concern is, if the guardianship board refuses to appoint a guardian, then nobody will be acting on behalf of the patient.
And for the patient's records, if the patient is one of the categories of people I have mentioned, and that is a patient cannot make the decision for himself or herself, then whom should be given the authority by law to do that on his behalf, that is the patient's behalf? Now, in consideration, because we already knew that there were such problems, therefore we have come up with the in the third clause, a person to make that decision on behalf of the patient, and that is a substitute decision maker. Now, where there are guardians, of course, that would be the guardian, or otherwise, if it is a court-appointed person to take care of the affairs, and that would be that person. Well, we have discussed at length last time when we talk about family members, they are family members, and it is very difficult for us to prioritize family members. It is the elder sister, or is it the elder brother's opinion more important? Is it the mother's opinion more important, or father's opinion more important? The law cannot say anything on that. It is just that in accessing our scheme, and where the records is to be accessed, this is not about a life and death situation where a life is to be saved. We're not talking about that kind of a juncture, but rather the family members have different opinions, and they perhaps talk to their medical officer, talk to the social worker, etc., try to come up with a decision. But while there are controversies within the family, we will definitely not step in to say who is right and who is wrong. That is the difficulty that we have. And also, where a patient does not have the four categories of people, let's say this is an old person in an old age home with no relatives whatsoever and no friends, then the medical provider will have the authority to make that guardian decision. But in so doing, they will have to take into the best interest of the patient into consideration. Now, Mr. Zheng said that I have still not resolved the problem, and that is where there are controversies. Yes, indeed, that is a situation where we cannot step in, and I have talked about that just now. And secondly, where the guardian board does not want to appoint a guardian, and given the new bill, now that we have the chance of a new bill, why do we not make the guardian board also have to take care of our situation as well? Well, the response is that for this kind of consequential amendment, these are amendments which are small, and because of certain situations, we may have to amend other ordinances. But if we have to change the terms of reference of an authority, then or a body, then we'll have to go through the related authority concerned, or the body concerned, and the law that governs that particular authority to change that terms of reference. We cannot do so unilaterally here. I mean, that is my supplement. And Mr. Chung, I understand the response, but I still think that it doesn't solve the problem. Now, if this is about the limitation of the powers of the guardianship board, and this exceeds the terms of reference of the board, then I would say that this is not in keeping with the developments of electronic health records or health record sharing system. Now, if we want to add a so-called seventh category, whether it is appropriate or not, let us put that aside for the time being. But I think internally you should have had some communication, and they should have given you some response. And that is, if there should be an amendment, are they for or against, or for what reasons? But rather to say that they're not responsible, and we just sit here because there is but one government. If you say you're not responsible, who is? Right. So this is a social welfare department, labor department, and perhaps they should tell us what their thinking is, rather than for us to write to them and ask for their views. Of course, we cannot force them to change their ordinances, but I'm sure that we can ask them to respond to our members' requests or concerns. Actually, in the December meeting, this had already been raised, and indeed the decision is not with us, but with the Labour and Welfare Department, and I have referred this to our colleagues over there to see what their views are. We have already done that. We have already provided them with the background and also the concerns to them. And in our December 8th response, we will include the response from them. So you are saying that you will have a paper? No, we will basically be paraphrasing them. We are definitely not answering on their behalf. We cannot comment on their policy ambit. All right, we will see what they come back with. Dr. Leung. I would like to follow up on a point raised just now by the government concerning the exclusion or exemption of the hospital authority and the health department, and the arrangement and the reasons and the explanation. Well, they say that this had been discussed and it's been agreed upon by all parties. But on the other hand, there were a lot of things that were not thought of at the time. And, well, actually, people can change their minds. Well, the Medical Association had already written to say that they are concerned. So let us not say that they have agreed and they were supportive before. And further, as mentioned just now, even if this bill is not passed in this 1 year, well, this 1 year is not a problem because the electronic health record will still be developing. It will not disappear all of a sudden, would it? As for the reason behind, you raised 2 points there, and that is why public bodies do not need the agreement for sharing. You seem to be saying that it takes a lot of resources, human resources, to process that because there will be millions of patients. Well, when the patient goes to the private hospital and their health records are with the private hospital, and if you want to access the records there, you have to ask the patient whether you can access his records in the private hospital. It is not that once he has participated in the system agreement, they will automatically provide the information from the private hospitals to you. I mean, there are patients who just want to keep that information from you. Don't ask me why, but they just want to do so. And that is why they go to the private hospitals. Now, for the private hospitals, if they want to get the records from the public hospitals, they have an agreement. They have the sharing agreement as well. And so the private hospitals will be able to access the public hospital's records of this patient. And that's exactly what the patient wants. But on the other hand, the government also, at the same time, will immediately be able to see the records, the patient's health records in the private hospital. And that is a big loophole, you understand? You see, in your bill, there are a number of procedures where this loophole is contained or this loophole is built up. One, you exempt the HA and the health department. They do not need to get the sharing agreement, and so they will be able to access the patient's records nevertheless. And also, the patient, after giving the agreement, the hospitals, public hospital, will have no limitation in uploading the patient's records into your system. Because all these different parts are linked up. If you put down a gate at some point, it already affords great protection to the patient. As for the Privacy Commissioner, in the paper that we're looking at today, he has certain suggestions, and one of which is to add a 12.7a. And that is, when giving this agreement, the patient can have, there can be certain limitations when the patient gives this agreement. Well, that is to say, there will, for certain things, there will not be mutual sharing. Now, that already saves a lot of work for the administration, the medical, the HA or the medical department. The ordinance does not allow the accessing of such patients' record. Whether they will take a peep, despite the law, to do so, I do not know. But what I'm saying is that at different points in the legislation, you can build in certain safeguards so that the patient will have more safeguards. And I have already mentioned how a patient will have his records made open to the public hospital by accessing public hospital information from the private hospital. I've already mentioned that. And also, the patient's sharing agreement. Once there is an agreement, but with a safeguard or a limit to what records can be shared or not shared, then that would already be a layer of protection. This is much like what the Commissioner had suggested. I mean, we can discuss that. Yes, I think we have all heard this, and it's being repeated. The administration, I think we cannot debate incessantly and not persuade each other successfully. Perhaps you can respond to Dr. Leung's reiteration, but when it comes to the bill, the clauses in the bill, well, actually the Privacy Commissioner already has certain suggestions, and when we go clause by clause, we may, apart from the Commissioner's suggestions, individual members may also come up with certain amendment proposals. Dr. Leung has convinced you or not, Mr. Chan? Well, if I can just explain the background, why there were two steps. First of all, the patient will have the right to decide whether he wants to participate or not participate in the system. If he does not want to share information, he can wait for certain improvements and not participate in the system. But on the other hand, we are trying to step up with the records or information sharing of private sector and public sector. And the HA and the health department would have the most information of patients. And in the consultation at the time, it was clearly set out that once the patient participates in the system, it would be deemed that the public hospitals or the HA will have access or be able to upload the information or records. Perhaps there may be changes in the future, one cannot foresee, But on the other hand, that was the public consultation results and also the committee suggestions. And after a few years of design, we have come to this state of conception. We cannot throw it all out and go back to the board and do it all over again. I can only say that there are certain bases and reasons for each party to have come up with their views. As for whether this is in haste, well, why are we in so much haste? This is a PPI, EPR, and it is, well, the doctors already have certain access to information, so this should not be run through hastily. Well, in response to that, the PPR is actually a unilateral access, and that is not good enough. We want it to be two ways. That is the design of the system. It is not about the HA or the private doctors benefiting either one of those, but really the patients, because the patients do patronize the private hospitals and also the public hospitals, the HA hospitals. And we would want to be able to see what they have been doing. And actually, a lot of patients come to us and say the private doctor had already done this and that, but the public doctor would say, I do not see those records.
Therefore, starting from last year, that is the last legislative session, well, this is already the second legislative session. We hope that the system can be launched as early as possible. Precisely because it's not a mandatory system, we can perfect the system in accordance with actual experience. New functions and modifications will be made in stage 2. But if we don't trigger the system, we don't have any basis for further modification. Well, after you launch the system, what about the one-way system of the HA? Will it continue to exist? You mean the PPI, EPR? Yes. Well, some people may want to use the one-way system only, that is the PPI, EPR only. Well, assuming that the bill is enacted, then what about this one-way platform at present under the HA? Will it continue to exist? Now, that's a one-way pilot scheme. When the two-way system is launched, this one-way system will be suspended. But of course, it won't be the case that if I start the two-way system now, the one-way PPI, EPR will immediately be suspended. Be it the private doctors, private hospital, and the patients, they need a certain time frame for adaptation. So if they want two-way sharing, they may not be familiar with the system and won't know what to do. So we won't immediately stop the one-way system upon launching the two-way system. There will be a period for adaptation for doctors and patients to understand the two-way system. And maybe workflows in private clinics and hospitals have to be modified as well. Well, after all these are done, then we can consider phasing out the old system. But the old system won't be phased out immediately upon the launch of the new system. Then I think you should maintain the one-way system for a very, very long time before you phase it out, because the existing one-way system provides more protection for the patients. Well, yes, some patients don't want the HA to unilaterally disclose the records to, say, private hospitals and clinics. At present, patients are more confident in this one-way system, so it has to be kept for a long, long time. Well, maybe when stage 2 is launched, all the problems will have been solved. Will this be solely the administrative decision of the HA, that is, in terminating PPI, EPR? Well, that's a decision for the Bureau. So you've heard members. Ms. Emily Lau, Sorry, Mr. Chairman, I was just now at the Electoral Commission meeting, so I was late. Well, we attach great importance to the views of the Privacy Commissioner. The Bureau told us that that would be difficult because consultation results were arrived at after a few years of consultation. Of course, the Privacy Commissioner has different views. Back then, when you did consultation, the views were already raised. Is that the case? But those views were rejected by you. Now, you treat the private commissioner's views as new views, right? And you may think it is unfair for you to start afresh, but we think the privacy commissioner's views are fair. That is to give the choice to the patients. But then the Bureau is telling us that this is a give or take choice. That's not really fair. Bureau, there are three issues here. Dr. Lao said that it's good that in the first stage it's voluntary participation. Why is it that in stage 2 he can authorize DHHA, he cannot authorize the HA or the DFA, which will have access to the records mandatorily? The patient can only have a choice for private clinics and private hospitals. But that's actually the suggestion in the consultation document. Just now, members raised a different view. Precisely, that's the result of the consultation exercise. Well, I asked whether in the consultation process that piece of opinion was already raised. Back then, did somebody say that patients should be entitled to a choice? Was that view raised in those 3 years of consultation? Well, back then, nobody actually said anything or object to the suggestion that HA and DFA should not have definite access to the records. But something mentioned privacy, and people wrote in about 2 issues. First of all, about the safe deposit boxes. Well, for example, they said, can we only choose 3 out of the 9 types of data for sharing? Well, I think both sides have justifications for their arguments. Well, even in the public consultation exercise, there were 2 schools of thought. And we understand the 2 schools of thought. And many organizations would like the patient to have more rights to control whether or not my data should be accessed by another party. So we would like to conduct a study in stage 2. We would like to find out ways and means and arrangements to give more protection to the patient. All right, so we've promised to do a study. And then individual members said that we might renege on our words. So they wanted us to add something into the bill to enhance the effect of that promise. So there is this clause that is similar to the concept of safe deposit boxes. So that's what has been proposed in 16A. Very soon we'll meet with the Privacy Commissioner to listen to his comment on this latest proposal and where we should place this clause. Wherever we put that clause should not be preemptive. But we understand that members want one more provision such that patients can impose restriction or control on his own records. Maybe in future he would like to add something. So that's why we put up this latest proposal. So we'll meet with the Privacy Commissioner soon in the hope that we can come up with a new version. And the need to know principle, we're asked whether or not we had conducted consultation. Yes, we did so. Of course, there is this need to know principle. But do we need to write this need to know principle into the bill? There had been several rounds of discussion on this. We raised this with the Privacy Commissioner. Eventually, the government agreed to add another provision on this need-to-know principle. So a new Clause 35A is proposed. That is, the medical institution concerned is responsible for serving as a gatekeeper. In the past, we also cited the example that even a security guard would be able to peruse your medical records. After reading 35A, the Privacy Commissioner's office said that that's a good clause, but they would like to something extra. That is, apart from responsibilities, there should be a provision to the effect that the patient's consent is required for each and every perusal of the records by the staff of, say, the private clinic or private hospital. Well, we're still discussing with the Privacy Commissioner, but this is a minor issue which we think can be resolved. Well, Mr. Chairman, from what he said, he's saying that in the past few years of consultation, the Privacy Commissioner participated in the process, but at the final stage, something new was raised. But of course, this always happens, because it's only at the final stage that our discussions are more focused. It may not be necessary to start another 3-year consultation exercise, but we have to work hard. I understand your logic. You've been working for a few years on this, and now there are new views. We would like to have consensus in the Bills Committee, so you please work hard. And now, for this existing one-way system with the DFH and the HA, that is the PPI EPL, is it voluntary? Yes, voluntary. Voluntary participation. And Dr. Leung Ka-Lau said that he would like to have this system remain. Now, if this bill is enacted, you'll have a new two-way system. Well, I think to give the patients one more choice is, of course, good. The patient can judge whether or not the new system is good for him. Under the present system, the doctors already know their patients. So if we have a new system and keep the old one, then that will be one more choice for the patient. And if the patient is confident enough, well, he can just opt for the new system. Yeah, it is still on PPI EPR. Can you make the transitional period longer? Well, basically, that's also our view. This PPI EPR is a one-way pilot scheme and has been popular. About 450,000 patients and a number of medical and health personnel are under the system. But of course, the HA has no access to the private sector's system. Under the new system, automatically, the HA's records can also be perused. So the one-way system has been successful, so we would like to expand that to a two-way system. So conversely speaking, in future, if you go to the public sector, you may want the public sector to have access to your private sector records. Now, 450,000 patients and some service providers in the private sector are already using the system. But of course, we cannot push them and press them to use the new system overnight. Doctors may want to train their nurses. Private hospitals may want to train their personnel to use the new system. They may have to explain to the staff the new system. So there must be a duplication period and gradually there will be more participants in the new system, then eventually we can make a decision on whether or not to phase out the old system. So I agree with members that we have to carefully monitor public feedback. Well, you cannot, we have to pay attention to the possibility that people may welcome the existing system but not the new system. We understand that. So the transitional period should be long enough and sufficient choices should be given to members of the public. Next, Dr. Kwokaki, first round. Chairman, I really have to discuss logic with the administration. From what I heard, you're saying that you had conducted consultation in the past 3 years. Now, the consultation results are finalized already and you cannot change them. But this has never been the attitude of the LegCo. Frankly speaking, the Bills Committee is the forum where all things discussed are scrutinized once more. And in the past, when we discussed certain issues, you had to obtain views from relevant bodies and individuals. That applied to us as well. For example, we had to refer to the Privacy Commissioner for more in-depth views, which were not raised in the past 3 years. To be fair, in our past 10 meetings, the Privacy Commissioner had provided us with a number of views that were not discussed in depth during the consultation period. So we must offer sufficient room for relevant bodies to revisit important viewpoints, like the concept of the safe deposit box concept and the patient's right to decide. Why are we spending so much time on this? The more protection, the more choices in the system, the higher the participation rate. Well, if you say you're not going to pay attention to anything, you go it alone, as Dr. Leung Ka-Lau said, if you're not to define who can access the records, say if you say that if the patient has to make known all records to the hospital authority and the public sector, that won't work. Say if the patient is obtaining medicine both from the public sector and the private sector, maybe the public sector doesn't give him certain drugs, and so he's getting the medicine from the private sector. Under the new system, the patient will be afraid that the public sector may cancel his appointments and entitlement after knowing what he's been doing with the private sector. So the solution is simple. Just give the patient the choice. Well, if the patient is given a choice, then basically we don't need a transitional period. Say for the PPI-EPL, it's a one-way system. Say if we have a queer patient, he only permits the public sector to peruse the private sector records, but not the other way round. Under the privacy ordinance, the records belong to the patient. Why can't I decide who can access my records? Why do we attach great importance to the Privacy Commissioner? You know that you say that this sharing system is for medical purposes, but if I'm the patient, my records are my property. It's just like saying, oh, if you sign this, you have entrusted the records to me, and in future I can decide for you. Then in future, you're just like the unscrupulous investment consultants, like those for London Gold. Once the customer has signed something, the consultant will handle everything until the end of the account. The government should not do this. Irrespective of the length of the buffer period, there must be provisions in the bill to protect the right of the patient. Honestly speaking, the patient has the right towards his own records. Otherwise, it's an outdated proposal. So, number one, the records belong to the patient. Number two, our discussion a few years ago was not as deep as now, not as thorough as now. And the Privacy Commissioner has offered us new viewpoints. If we genuinely respect those organizations and bodies that had offered us views, then we should pass these new viewpoints to those bodies and individuals to see whether or not they support these new viewpoints or otherwise. Number three, when I came in, I heard that some organizations were requested by the administration to send letters to the LegCo to urge us to pass the bill quickly. Now, this is not in order. Well, the government always mentions legislature-executive relationship. Now, this is not conducive to that relationship. Please don't do that. Don't exert pressure on us. I very seldom saw letters from bodies that pressurized us to hurry with our work. Well, this has nothing to do with life-saving. Well, those of you who are in LegCo will remember that back in those days, we, even for very urgent proposals like those during the SARS period, still the administration had to come to LegCo. You see, the injunction orders proposed then came to LegCo. So I really regret this, Mr. Chairman. I absolutely cannot accept that. There are two aspects here. For the views expressed by the deputations, some deputations and individuals might have expressed views to members, but of course they might have already written to the Bureau to express their views. And this time, they're writing to the Bureau, not to the LegCo. Dr. Kwok mentioned the point that although we conducted consultation a few years ago, that doesn't mean that we cannot change anything now. Well, yes, but precisely after the introduction of the bill, we've gone through many meetings here in the Bills meeting, and we had made some changes. And the Privacy Commissioner has come up with new viewpoints.
And there are some new amendments we've made only this year. And you say that, well, this is this review committee. Perhaps we have to be more clear on the Constitution. And also, there's a need-to-know principle in your consultation. You need to have a stipulation. Well, our view is that in our consultation, the main principle is that if it is something that is with public support, we should follow that. As for the system and the main structure of the system, we should follow that after the consultation. But on the other hand, if there are certain amendments which will not change the main principles of the structure or make it or will not make it unwieldable as a structure, then we can consider those. Now, as for the Commissioner's new 6-point suggestion, in fact, 4 of them we have already taken on board. And the 5th one is exactly what we're going to talk about today, the need-to-know principle, and also the not as limiting stipulation, but also at the same time honoring the safe deposit box idea we will be talking to them about. And then there is another one, which is a little bit outside of our terms of reference, which is miscellaneous misuse of data. So anything that is misuse, miscellaneous misuse, we slap a fine of $5,000 or something. That would be increasing the powers, and also to come up with something called miscellaneous misuse. I think it will be difficult to put that into the drafting of a law, and will be difficult for us to take that on board. Now, having said that, we have already taken up the concerns of the members, the stakeholders, the commissioner, and made a lot of amendments. And going back to Dr. Leung's point, rather Mr. Kwok's point, and that is the original design and the principle of our system. It is a facilitation for sharing of health records of patients between private and public hospitals. And that's why the system, when we first designed it, would be for the patient's records in the 9 categories will automatically be shared within the system. Now, if we are going to make amendments, first of all, we have to make amendments technically, systematically, and that will take a year. And also for frontline workers, it will be different from the original conception. If the person says, I actually do not want the HA or the government to know my information, and I go to hospital or private hospital A or private hospital B, and the government would not therefore be able to access the information that I have. Well, for that kind of a person, perhaps he should not go into the system at all, not provide the agreement at all. But I do not rule out the possibility in the next stage, because exactly we have agreed that we will do a study to increase the influence of the patient, and also according to the Privacy Commissioner, we will consider a stipulation where the patient can exercise certain restrictions as to what is to be shared and what is not to be shared. Then at the next stage, perhaps we can think of an arrangement whereby the patient can choose the HA or the health department, choose one or the other. I do not rule out that possibility, but that is a major amendment. We will have to go complete this round of study before we consider that, and perhaps do a round of consultation. Yes, there's another point I've asked the chair already just now. There are certain, well, as mentioned, the commission had come up with 6 amendments, and 4 have been taken on board, 2 are under consideration, as mentioned. Will we be going to the relevant stakeholders and, let's say, patients' rights bodies, so that they are in the know as well? I mean, this is important, isn't it? This is about patients' rights, after all. I do not know whether this will be the Secretariat doing a summary or the administration. I understand. I totally understand. We have a time limit. No, I'm not talking about time. I'm saying it may be overly complicated for consumption. And there are certain amendments which have been raised by the government, and we have not come to clause by clause. So these are but suggestions. If we can have a summary as such, which will clearly lay out the relevant arguments and provide this as opinion to the relevant bodies by way of report on our progress, I think that would be good. But of course, we have to strike a balance. If, let's say, after a few months we do another round of consultation again and public hearing again, then really we are going into cycle after cycle after cycle. We've heard, after all, many of the viewpoints already. And can we not do a summary and lay out some of the major points and make that document available on the website and available to certain bodies? And that's by way of information provision. I think that can be done. Any special views on that? The government perhaps can later on liaise with our secretariat to see whether there are certain major points you want to put in at this stage. Otherwise, the secretariat can also make a first draft of the summary. Well, Mr. Chair, I suggest in the last public hearing there were some 20 to 30 deputations coming up. And for where the government had agreed to make amendments and to inform these deputations or bodies about the amendments, I'm fine with that. But on the other hand, we haven't even gone clause by clause. We cannot tell them what some of the CSA are. I think after clause by clause, before the report of this committee, we can tell the bodies as to some of our thinking concerning amendments. That would be fine. Yes, exactly. This is just about the direction of amendments, because we are not in gone through clause by clause, and we have definitely not gone through the wording. I don't think we'll be misleading the bodies into thinking that we've completed the work. There are some initial suggestions from the Privacy Commissioner, and there are certain counter responses from the administration. I mean, if we summarize those, I think it would not be misleading other people into thinking that this is a final decision. And of course, if they have certain thoughts which are not made known to us yet, they should also take the opportunity. I think that's important too, rather than to have people criticize us later on that they were not informed of major decisions at important junctures. Yes, Mr. Chair, it was mentioned that there will be another round of discussions with the Privacy Commissioner concerning their suggested amendments. Perhaps the administration was wrong. It is 12.7a, not 10, right? I just want to clarify that point. It's 12.7a. All right, the suggested 12.7a, the administration is saying that it is worth some consideration. Perhaps this is not the right spot to put it, or the wording can be further refined, etc. But this is a progress for electronic health record sharing, and the people at large, including patients, are more and more heightened in the sense of privacy protection. As for the safe deposit box, there are different views, but today I see the Medical Association's submission to the administration, and Dr. Leung had also spoken, and having regard to those, I think it has already alleviated a lot of concerns. Before, actually, I've heard a lot of views opposing the safe deposit box concept coming from the doctors. They feel that if they do not have all the health records, that it would actually adversely affect their diagnosis. But having looked at the Medical Association's views, it seems that most of the medical officers are respectful of patients' rights and patients' privacy. So if we do not want to drag this on, perhaps the administration can tell us as soon as possible as to what their discussions with the Privacy Commissioner had been, and to see if we can reflect whether that can be reflected in the bill. Hopefully we do not need further amendments because that would be complicated. And another point, the administration responded to my concern raised at the December 14th meeting, one of which was the sharing, the supervisory committee for sharing, record sharing. The response from the administration I already note, but I do not see for this steering committee, I do not see this terms of reference and the Electronic Health Record Commissioner and how they overlay or how they mesh. I do not know whether the Commissioner will have to be responsible for the steering committee, or the steering committee is but an opinion providing body. The steering committee it seems, will have different stakeholders' participation, but not too many sectors, mostly from the government and from the medical field only. And in the future, if the electronic health sharing is to be developed, then there should be more IT, patients groups, and also a broader medical representation. So there should be, I would suggest, an electronic health record sharing development committee to review from time to time the development of the system, and also to look at overseas experience and developments, and to review and look at future developments. I think with more participation from different sectors, it would be good. And I have provided a lot of information and papers as well concerning the development. Apart from corporate MECM participation, there is a board and a national board of e-health, and so the different organizations actually coordinate among each other and follow up on the development of electronic health record system. The steering committee, even after the first phase of development, we will maintain it. There are 4 working committees. Also, apart from government officers, there are members from the sector, medical sector. There are 4 medical-related bodies and 3 patients groups represented as well. And also for technical aspects, the committee also has IT members as well. So in the future, we believe that we want to keep these consultations structure, and the commissioner will also be a member of this bureau. And we will be listening to the views of the committee for our next step of development. That is the first point. And the second point, we will continue to take note of overseas experience in mapping out our future stages. Now, this is a new thought, that is, electronic health record committee, a new committee. So this will be bigger than that. This is about e-health, right? So this is broader than the system steering committee. So it is in terms of reference and in terms of scope. Now, the commissioner and the steering committee's terms of reference, what exactly is a relationship between the two? A steering committee basically will comment on the broad strokes development. For example, the second stage of work, the main directions of work, and they will provide suggestions and recommendations. There are specialists and experts on the committee, so it is a consultative body. It is an important consultative body. Exactly. So this is consultative only. They are not responsible to each other. So it is not a board as such. All right. Having that clarification, Mr. Chair, we go back to the same question, and that is whether this commissioner will be all-powerful and it will be unchecked, his powers will be unchecked. Well, we have to think about that. And secondly, for the development committee, in fact, I've raised that before. It is not new. I have looked at other industries, the IT industry, and we have heard from the IT sector that they are not fully participating. And let's say the safety box concept that we've talked about, some say technically it's infeasible, but how can it be technically infeasible? The reason why I've come up with this concept is exactly because of that. Perhaps it is not directly related to the bill, but I hope the administration will take this suggestion on board. Now, there's another question left unanswered, and that is, the government should not go back to consider putting the safety box concept into this bill. It's not about whether that should be enshrined in the law or not, but how it should be enshrined in the law. Mr. Chan, I want to go back also concerning this commissioner that was set up in the future. This is not the Equal Opportunities Commission with a separate office but it is more like the tourism commissioner, more like the AMO, the Antiquities Commissioner. So this is a civil servant, and also this is so as for the steering committee, it is a consultative body, and it is much like the traffic committee or the or consultation committee or the medical consultation committee. So it is not a board, it is not an independent body. Perhaps commissioner is a term that elicits certain misunderstanding. Now, whether it is a medical association or other sectors concerning privacy, everybody is concerned. And in the latest submission from the Medical Association, they have also sounded the same. That is, this privacy issue should be resolved as soon as possible by the government. But even for the Medical Association, expressing concern for privacy and for their view concerning safe deposit box, for instance, we must not equate the two. For example, if I look at 2014, July, in their own circular, they say that the board of the association is diverse in their views concerning safe deposit box, and the article lays out the two fors and the against, and most of the members are mostly against. There was a vote taken mostly against safe deposit box. Now, this is July 2014, not that long ago. I'm not saying that I am in support and therefore I do not need any other arguments or basis, and therefore we have to put in or not put in safe deposit box. I'm not saying that. But on the other hand, we have to empower the patient for certain protection. But before we do that, we do not have a concept, we do not have a name for that mechanism. Any other questions? Emily Lau? Yes, Dr. Leung, Dr. Kwok, to supplement Dr. Kwok's point, consulting the relevant bodies. I think this is excellent. And I do not think that this will add a lot of workload for our secretariat because the information is all electronic. All we have to do is to provide the information to these bodies. We are saying that there's new information, new views we have received, and here they are. Look at them. So that you will be in the know. If you have new views on top of those, raise them to us. Because all the information is already there. Whatever we have, we will share. I mean, put it up on the website, make it public. But of course, we also send an email saying, hey, look at this. We are discussing this now. Do you have any response to this? Any other views? No? Next? Well, we have discussed these few papers, and we should really be Mr. Chair, concerning computer crime and this new bill, there should be a comparison between the two. Is this the right time to discuss this? Well, absolutely. This is the right time. Yes, this is the 11th of November. Well, last time when I raised this, you said it's not time yet. No, it's time. I didn't know you were waiting. We're talking about all the three papers at the same time. Well, if we look at the schedule, the comparison, the existing ordinance, privacy ordinance, and also unethical, unlawful getting of information from the computer, it seems that this is beyond the ordinance. But on the other hand, the view from some is that the ordinance seems to be all-encompassing. I just want to confirm with the administration. Your department's view is consistent with the view of the others, is the other departments. Is that right? No, I think I have to open the document. Perhaps the administration should respond to that question first, and then I'll come up with certain examples. Shall we go about it as follows? Yes, for the existing ordinance, you're saying that because it is lacking, so you have a new bill, right? But your understanding may not be in sync with the other department's understanding. Yes. Perhaps the DOJ or the secretary can give us your views on this. Well, actually, the DOJ should have a consistent view, I should think. Concerning the appendix, 11th of November, in response to Dr. Leung, for the 6 crimes and the crimes without this ordinance, we have made a comparison of the two. Why do we have to add these 6? It is for a reason, even though they may seem to be very much similar to some of the others. Now, this is new, the electronic health record sharing system, and some new crimes, types of crime, to attack this system. Not a computer system as such, not a computer, but specifically this particular health record sharing system. So this is not to be protected simply under the criminal vandalism or the electronic data protection. And also for research purpose. If the information is to be obtained for research purpose, then there are certain criteria that which have to be satisfied first. And if these are not satisfied, then it will not be allowed. And these have also to be these have also to be specified as well. And they will not be inconsistent with previous clauses, here or otherwise, as we have understood from the DOJ. I'm not saying that they are inconsistent, but if I can give you an example. First page. Let me look at the document. Behavior. Relating now. Telecom. Are you saying that if the person, the act, if the person is doing this, performing this act, but not by telecom or telecommunications, will it not be a crime? 41.3. The new offences proposed. The act by telecoms during the course of a computer to perform any function to obtain unauthorized access to any program or data held in a computer. Now, if this is not by telecommunications, then it would fall outside of this the terms, would it? But this is a telecommunications ordinance. Of course, it will have to be by communications means. But if it is by criminal ordinance, you may be saying that this clause, that clause would already suffice under criminal act. Why do you have to specify by telecommunications here? That is Dr. Leung's question. Because a person may choose not to use telecommunications means. So it seems a person may have the impression that if it's not performed by telecommunication means, then it is not a crime. But on the other hand, the other acts not by telecommunications will be caught elsewhere. You see, that may be his argument.
Well, Dr. Leung was referring to the middle column. That is what are regulated under the Telecommunications Ordinance. So access to any program or data held in a computer of any institution or body. And here I would like to write an ordinance on access to electronic health records. In the past, there are no electronic health records. So if you unlawfully access any electronic health records, then I can prosecute you. That's why we are not using existing laws. But when there is an offense, which law will we invoke to prosecute the person concerned? It really depends on the facts, circumstances, and the prosecution considerations. You want to prosecute the person for wounding, homicide, or what? The first column is about the new bill, and then the middle column is about the existing scenario. Mr. Chairman, he's not answering our questions. Dr. Leung's question is like this. Well, after adding this new description, will you be plugging loopholes in existing laws whereby you cannot prosecute for such offenses? So you would like to write this clear in the new ordinance. Apparently, you are narrowing down the application of the existing law. But we want a new law that's more broad in coverage. Well, let's not talk about the Telecommunications Ordinance. Let's refer to the Crimes Ordinance, Section 161. 4168 has a wider coverage. That's what you say. It's not just access. The new ordinance will also regulate intent to commit the offense, dishonest intent to deceive, blah, blah, blah. So what if the person doesn't just access your records, but immediately alter the records for whatever reasons? Well, he does not actually retrieve the information, but just alter the records, damage the records. Then it's not an offense. No, it's an offense. No, under the new bill is an offense, but under the existing law, that's not an offense. You understand what I'm saying? I, of course, understand. I will follow up on this issue from another angle. I'd like to ask Mr. Chan to answer this question first. For the previous example and the present example, it doesn't mean that when this new bill is enacted, it will replace the Telecommunications Ordinance and the Crimes Ordinance. No, that won't be the case. When something happens in future, depending on the circumstances and the facts, we'll decide on which law to invoke. Since we already have the Crimes Ordinance and the Telecommunications Ordinance, why should we have this new provision? We're also talking about alteration, damaging of records, damaging of computer systems, and so forth. I emphasize most that we would like to cover all computers and all telecommunications. But I want to be even more specific. If the person damages the electronic records in the system, then you can see in 4168 a number of facts are covered, including damages, destruction. Well, if you alter our electronic records, if you damage our electronic records, I'll invoke the new bill to prosecute you, then we'll be more precise. But that doesn't mean that we cannot invoke the existing laws. Well, if you use a hammer to damage my computer, then of course that's a crime. But damage to electronic records, health records, will be even more specific under the new bill. Dr. Lau, any follow-up? Otherwise, I will follow up. Well, we still have a little bit of time. I'll ask my question and see whether you can answer it. Anyway, we have to finish by 12:45. Anyway, I'll ask this question when it comes to clause-by-clause scrutiny. For Section 161 of the Crimes Ordinance for dishonest use and access to computers, it was applied too broadly in the past. In recent times, a person stole his boss's mobile phone and spent $120,000 on telephone calls. Strangely, the same ordinance, this ordinance was invoked to prosecute him. In principle, for individual offenses, if you can be clearer, for example, in this bill, if you can make yourself clearer, it's better. Otherwise, it's just like an all-powerful key to prosecute under the crimes ordinance, that is, dishonest use of computers. So it's reasonable for you to use a more specific offense under this bill. But then, this word dishonest again emerges at a number of locations in this bill. So I'd like to know the definition for dishonest or dishonesty, because only God knows whether or not I'm honest. So how do you define honest? In Hong Kong's laws or in overseas laws, is this expression a common term of expression in their definitions? I'd also like to know this. And then gains, losses, etc. are also defined in the footnote, but there's no definition about dishonest. So is this a kind of legal language that is you assume everybody knows or understands, and you leave it to the judge, or you give flexibility to the judge for defining the term? So what are your concepts here? I really don't know whether the bill is an improvement or otherwise. Well, sometimes in the past you would like to have clearer laws. Here you do not want to use generic laws for prosecution. At the same time, you continuously repeat the term dishonest. So in future, are we going to have unclear terms such that members of the public don't know what to do? Members of the public are already doubting how they're going to challenge Section 161. And should the word dishonest remain? And then now we discover that the word dishonest appears in almost every provision. Mr. Chan, let me suggest this. Well, these few provisions will be our focus for sure when we come to clause-by-clause scrutiny. So should we invoke the existing laws or this new bill? There are two schools of thought. And Mr. Chairman, you particularly mentioned that the word dishonest seemed to be vague. But dishonest is only the first step. There's a second step. That is the dishonesty leading to loss or gain. We have two steps. I'm also worried that in terms of law enforcement, the reverse may happen. Nobody can stop the police or the Department of Justice from using this new bill for prosecution, because the definition under the existing crimes ordinance is broader. So, in future, the police and the DOJ may want to use this all-powerful key under the crimes ordinance instead. If that's the case, then why do we need this new piece of legislation? So, there are challenges on both scenarios. I believe our DOJ colleagues have already heard you. Next time when we come to clause-by-clause scrutiny, we'll offer an explanation. That is, which practice will be fairer to the person concerned. If there's no objection, if there are no further questions, I have to declare the meeting adjourned. And have we fixed the date for the next meeting? End of January. End of January? 27th. The 27th of January at 4:30 p.m. 4:30 p.m. Whoa, there are clashes. Is it the 27th of January? Well, I think the Secretariat will go back and discuss with you. If there are too many members unavailable or if that date is not convenient for you, we'll try to see whether we can fix another date. The next 2 months will be very busy. It's not easy for us to find a time slot. After this meeting, the Secretariat will first consult you and then inform you of the date and time of the upcoming meetings. Oh, you are not available. Well, the major members and members who attend often are not available. I think we have to accommodate them. But of course, we're not trying to bypass those who don't come frequently. All right, we'll fix the date later. Meeting adjourned. Thank you.